I've met a lot of you today, and I think what's most interesting is I travel 400,000 miles a year. I'm in academia, I'm in industry, and I'm in government. And you are a totally different crowd than I usually see. So, Daniel, congratulations. I can tell you, the Exponential Medicine crowd must be those optimists who are going to change the world and not just talk about it. So, well done. Well, let me tell you a bit about what I've done in the last month or so. In traveling 400,000 miles, you get to see lots of different cultures and lots of different people, lots of different IT problems. And I'll be honest, the problems are really the same all over the world. Maybe the cultural context is different or infrastructure is different, but the problems are very similar. And so what have I seen? In Japan, you have this profoundly aging society, 25% of the population over the age of 65, a birth rate of 1.4, and hardly any primary care physicians going into the profession. What are you going to do? In Germany, in Italy, in the Nordics, same sort of issue. You're starting to see this incredible aging society. But wait, everybody's living longer. So healthcare costs are going to go up as you develop chronic disease, as you see more cancers. And of course, there's a mental health burden. Across the world, no one's really addressing the mental health burden very well. Increasing anxiety and depression. And with low birth rates, there's not going to be anyone to pay for the care that's necessary for this aging society. And you're not seeing enough clinicians, and especially in rural areas, you're not seeing a distribution of the kind of services that people need. So what Daniel asked me to do today was, after we've had this afternoon, he said, summarize the big themes. What should we work on? What are the problems to solve? How are we going to solve them? So let me take you through a few countries first, tell you about their big issues, and then we'll go into the themes and what we can do about it. So a few observations from just the last 2 months. So China. I imagine there are a couple of you from China. When you visit China, what you discover is there's no Epic, there's no Cerner, there's no Athena Health. In fact, every Chinese hospital has an electronic health record, probably built by two guys down the street, that is totally unique to that hospital. Right? And the hospital can work just fine as a silo of care. But ask any hospital CEO in China, can you share your data with a hospital next door? The answer is no. So what does China need? China needs a first of its kind universal data set. How are you going to describe the data elements that are necessary for care coordination, including traditional Chinese medicine, acupuncture and botanicals? Now, for any of you who've worked in China, you know when China decides to do something, it just happens, right? So, quick story. I was in Hangzhou, and I said, you really need a national healthcare ID. But I know you're going to spend years debating privacy and data standards and formats and getting everybody to agree. I came back 6 months later, and 8.2 million patients had a national ID and a biometric card that could be used to go to a hospital or rent a bike, right? And this is how fast China moves. So in the next year, what we're going to see coming out of China is a small pilot. The mayor of Shanghai said, let's just do a really tiny pilot. We're going to start with 1 million people, tiny. And what we're going to do is look at their longitudinal health over their lives. We're going to run the Framingham project of sorts, but it'll be Chongming Island, 1 million patients sharing their data. And I said, well, what about privacy? The answer is, it's for the benefit of patients and society. It's okay. Just go do it. All of this will happen over the next year. When I was in Japan 2 weekends ago, I said, you have this interesting challenge. You've got earthquakes in Hokkaido, you've got typhoons off Shikoku, and you've got an erupting volcano in Kyushu. Don't you think that cloud computing would be a good idea? In fact, using the internet to share records and ensure that there's going to be in a disaster the ability to recover rapidly and coordinate care. They said, well, the cloud is very frightening. How do you lock it at night? How do you make sure that it hasn't been hacked or compromised in the internet? The internet is just a network of malfeasance and thieves. Couldn't possibly use that. And now Japan is recognizing if it's going to solve that aging society problem I talked about, it's going to need to start embracing the cloud, the internet, the data exchange necessary to coordinate care, especially in rural areas. And we'll be talking about telemedicine and telecare in a minute because they're going to need to embrace that absolutely. Now in the US, we often talk about interoperability and the lack of data sharing. And your records, well, maybe on your iPhone in 2018, you can download a number of them to HealthKit, but still, it's hard. Well, how did New Zealand solve this? If anyone's from New Zealand, you know how many electronic health records are there on the South Island in New Zealand? One. Just one, right? You know, when you got 5 million people, you can do stuff like this. Or in the UK, Scotland decided to have an emergency medicine record for the entire population. So if you go and see an emergency physician, they know your medications and your problems. They know your labs, your RADs, your care plan, and your care team for the whole country. Now, the UK did ask a number of us to work on a healthcare IT strategic plan. And so we reviewed everything NHS England was doing. And what we concluded was great people, good resources, but not a lot of the kind of expertise that you folks have. What the UK really needs is innovators trained in the intersection of medicine and technology. And that's what the UK is committed to do. Over the next year, you're going to start with a cohort of 300 experts being inserted into the NHS with all of that clinical technology expertise to optimize their technology. Now, what about the Nordics? A couple of comments about the Nordics. Now, here we are in the United States, 330 million people, and we have quite the range of privacy concerns. Right? So you have people like me, I have no privacy of any kind. And that means, because 15 years ago, I was the second patient in the Personal Genome Project, I had to sign a consent that gave up all of my privacy, including my genome, my microbiome, and my stem cells, forever. And if you want to go read it, personalgenomes.org, patient number 2. You can see every disease I'll ever develop and what I'm going to die of. Right? And then you've got patients, like if you ask my mom, would you share your medical data? She said, well, maybe my flu shot, but certainly not much more. Well, what's happened in the Nordics? So Finland has passed a law saying that all of your lifetime medical data, anonymized and aggregated, will be available for the benefit of society in perpetuity without consent. And the idea is, if we're going to do this machine learning that you've heard about today, you need curated data. And if it's aggregated and de-identified and used for the benefit of society, Finland has decided it's okay, we'll do that. And similarly in Norway and Denmark and Sweden, there's just more common agreement about the sharing of data for treatment and the benefit of society. Now, I served the Bush administration for 4 years, the Obama administration for 6 years, the current administration not so much. And what do we see in Washington today? You've probably seen a lot of rollback of regulations. And actually, the rollback wasn't necessarily so bad. For those of you who lived the dream of meaningful use, right? We ended up creating a slight burden for our clinicians. Some of you may be familiar with that. And how did we do that? I mean, some of you may have been there when we wrote those regulations. And here's what happened. The FDA said implantable devices are really important. So you should have every doctor at every visit record the implants in the patient, so if there's ever a problem, we can fix the implant. Well, that sounds okay. And the CDC said, well, Ebola is bad, so you should have a travel history at every visit. And then Medicare and Medicaid said quality needs to be measured, so we should have 20 quality measures, numerators, denominators, and every doctor at every visit just needs to enter all that. By the time we were done, there are 140 required data elements to be entered at every visit while making eye contact, being empathetic, and never committing malpractice. It's not possible. And so what you're seeing coming out of Washington now, this Promoting Interoperability program, this will narrowly focus on just 4 goals. Make sure we're managing medications safely, especially around opioids. Make sure that we're sharing data with patients, as you just heard e-patient Dave talk about. Make sure that we're using data for public health reporting. And then making sure that we've built these, what I'll talk about in a moment, application program interfaces so that data just is more liquid for a variety of purposes. So a very narrow set of focuses lowering the burden on clinicians. And that's actually probably good. It's actually good for you too, because it encourages innovation. Now, India has done something quite spectacular. And I know this is a little controversial, but Aadhaar is a probably necessary foundation for a society to be able to share data about you. Aadhaar, the idea that we'll know who you are, right? So if your name's John Halamka, that's easy because there are only 13 Halamkas in the US. But if your name is Maria Garcia and you're in California, there is very little hope that your data can be coordinated across multiple sites. So Aadhaar uses demographics and biometrics to uniquely identify each person in India, at the moment used just for government, not private industry. But the Gates Foundation is asking questions like, how is it we can start tagging data gathered about you using Aadhaar identifiers for the purposes of care coordination? No matter where you show up, your data follows you. And making sure you got the right TB meds and that you were compliant with those TB meds. So again, Aadhaar, very, very politically challenging topic, but it is an interesting solution to a problem most countries have. Who is the patient? Now, Africa, slightly different problem. For anyone from South Africa, you may know 65 million people, 16% have HIV. Very mobile workforce, hard to track patients as they go from clinic to clinic. Gates Foundation funded the creation of some biometric tracking there. We built $100 field-ready biometric scanners for fingerprint and iris, using Raspberry Pi, by the way. And these are used to tag laboratory results. So as you show up at clinic after clinic, the data's following you, sent to your phone, so you have a copy, but the clinicians can say, aha, for that eye, we've seen these lab tests before, and therefore I can understand whether you're getting appropriate treatment. So these are some of the interesting things being done around the world. Now, again, Dan asked me to take a look at the afternoon. And so I'm going to go through these technologies and some use cases around each of them that I think are what the world needs, and they're somewhat practical. They may not be as imaginative and far-reaching as some of the speakers suggested. And I know this looks a little bit like the Gartner hype curve for 2018, but I really am seeing across the world the machine learning, Internet of Things, using analytics, especially interoperable standards like you heard Dave mention, FHIR, Telemedicine and Telecare, and little bits of blockchain in the right contexts with the right use cases. Be very, very careful when someone comes to you and says, I've just got an initial coin offering. It's going to be great. So we'll talk about the practical use cases for blockchain. Okay, so machine learning. I think we all can recognize, based on the burden that I told you about that regulation caused, that clinicians are not currently practicing at the top of their licenses. In fact, I think some of your speakers have said, well, they didn't actually say AI would replace doctors, but how about this? Why don't I be controversial? If AI can replace your doctor, AI should replace your doctor, right? Because what do I want a clinician to do? I want a clinician to listen to me, to respect my care preferences, to help me guide through all the possibilities. And if they're assisted by a machine learning application, that's fine, totally fine. And there are lots of ways that machine learning can help. So I've seen many, many startups that ask, how is it we can reduce the burden of documentation? Well, I'll tell you that in the emergency department where I work, we're using human scribes, right? You make the doctor much more efficient by having a human scribe follow the doctor around and do the documentation. I think that's not the best use of human potential, right? Certainly natural language processing and machine learning techniques can take us to a much more automated way of doing documentation. I can imagine Alexa just listens to the doctor and patient talking, and what do you know, that a patient or a chart appears, a doctor reviews it and signs. The technologies that reduce the burden, absolutely helpful. Now, Daniel, I went to medical school in 1984. See, I'm older than he is. And you know that 50% of what I was taught in medical school was wrong. I just don't know which 50%. That's the problem. In fact, I was taught that you better give, all postmenopausal women have to get estrogen. Otherwise, you're committing malpractice. And now you're taught that is malpractice, right? So there are 800 papers published in my field every week. I'm a little behind in my reading, right? So anything that can augment my capacity to understand evidence in decision-making is absolutely a positive. And what about enhancing throughput? So it turns out Daniel's a totally healthy guy. You know, he's thin, he has no comorbidities, but he needs his appendix out. How much time does Daniel need in the OR? Well, the answer is we give everyone an hour, right? I mean, probably since Osler, we've been giving everybody an hour. What do? We put 11 petabytes of patient-identified data in AWS and simply used the machine learning algorithms, the very approaches you've heard of at this conference, and asked questions like, here's a guy who's healthy and thin with no comorbidities. How much time have 1 million patients just like this guy needed? The answer is 25 minutes. So we then began to schedule the Beth Israel Deaconess OR slots using the machine learning output. What happened? We freed up 30% of the OR schedule. I mean, how often can you turn on a simple intervention and affect anything by 30%? And then what did we do with that 30%? We created a mobile app, which I'll, for lack of a better term, call Open Table for Surgery. You know, I'd like an appendectomy, table for two near a window, 7:30, and filled all that empty time enhancing throughput. And what about the patient experience? Well, quick story for you. About 5 years ago, my wife was sitting with my father-in-law at dinner, and they were chatting. And he said, monkey carpet table brass tacks. It's like, what? Monkey carpet table brass tacks. What was going through his brain and what came out of his mouth just didn't line up. So what did she do? She called me and said, well, do I call an ambulance? Do I go seek primary care? Do I drive to Boston? What do I do? I said, he's having a stroke and broke his area. He's unable to speak. He's got kind of an expressive aphasia, a word salad. What you need is a non-contrast head CT, not at Mass General, but at the community hospital 2 minutes away. You could call an Uber and get faster service than an ambulance. Just get them into a CT scanner. And then through telemedicine, we'll take a look, and an expert neurologist will decide if it's appropriate to give TPA or other medications. And she did. Take him to that community hospital, and an expert evaluated the CT. TPA was given. He was discharged the next day, totally fine. Now, wouldn't it be far better, and that's actually been already mentioned at this conference, if the patients and their families had the tools to better navigate our healthcare system? Because right now, they either have to call a friend or guess. And with a machine learning approach, getting the right care in the right place, the right time, is of course what all patients want. What about the Internet of Things? In my home, I have a variety of under $100 instruments like the ones you see here. In fact, while I'm here, I can actually look and see, I've got a sensor in the mattress at home, and so it looks like my wife took a 20-minute nap this afternoon. But she slept really well. And it's not just that this is interesting in I think the one slide that suggested because we're self-absorbed. No, it's really important for a lot of disease states. And let me give you a quick example. So 6 months ago, I was diagnosed with primary hypertension. Like, how could this be? You know, I'm a vegan for 25 years, or I eat nothing but rocks and sticks, body mass index of 21, living right, no caffeine, no alcohol. People say I'll live to 100, but why would you want to? Well, my doctor said, being a CIO is actually really stressful, right? You're responsible for cybersecurity, downtime. You must be constantly innovative while creating total reliability and complete security, very hard. Why don't you take your devices in your home, measure your blood pressure when you get up? Because probably you're not stressed quite then. How about after your commute on the Massachusetts Turnpike? Very bad. After your first cup of coffee. after meeting with your boss, maybe we can figure out if there's a correlation. So I did all that. Turns out there was no association whatsoever with my lifestyle, my activities of daily living, and my blood pressure. So we did some tests. Says, yeah, the problem was your father had hypertension, his father had hypertension. It just took 57 years for it to show up in you. So we're going to put you on a medicine, beta blockers. Now, if anyone in the audience has ever been placed on a beta blocker, you know what I mean here. This is like negative espresso, right? It's like, I'll have 2 negative shots. It's like, 50 milligrams of metoprolol was the dose for a person of my size and age and gender. Now, does that data have any bearing on my ability to metabolize metoprolol? No, it is just some generic view of people of my rough size and gender. So what did I do? I used my Internet of Things devices. I said, let me take 25 milligrams, assess my mood and my energy, my blood pressure and pulse. Oh, it's all okay. Let me try 12 and a half, and I'm cutting pills in pieces here. And over the course of 72 hours, I was able to, with my clinician and my devices in my home, titer my medication to the value that was the right dose with the right output and the fewest side effects for me. And that's the kind of thing we all want. 3D printing of our pills and then assessment of their efficacy with the devices in their home. And one could comment on the Internet of Things. These are all, you sure get them on Amazon or Alibaba or whatever for $100. But I'm working in China with Haier Corporation. If you ever had a dorm refrigerator, they made it. The Raman Zhang, who is the owner or CEO of Haier, bought GE appliances for $6 billion just to get a US market share. Right? Powerful, powerful company. And they started to ask, maybe in the future, patients and families will gather around the hearth, gather in the kitchen. Maybe we should start integrating some of these capabilities into your appliances. So it's now just a natural part of your life experience. When you feel sick, you go to the kitchen, and the kitchen has all the tools you need to reach those services that may be consultative, diagnostic, or at least suggest the next type of care. Now, what about big data? I mean, you hear this all the time, big data, big data. I tell people I work on small data. It's the new thing, yeah. What am I seeing? You heard from a couple of speakers today, FHIR APIs, new liquidity of data, and that's actually okay, it's good. There are 26 different EHRs in the Boston region. No one maker of EHRs will solve the data analytics problem. So what we need to do is take the data from 26 different EHRs, aggregate it, add in some cost data, and then use that to measure quality, look at outcomes, and look at, for our risk contracts, total medical expense. And so I think that this FHIR revolution that you're starting to hear about is going to not only enable apps for patients to get at that data, that's all very good, but also new ways to aggregate data and look at your lifetime experience and not just a single silo in a single EHR. My hope is the data of the past will inform the care of patients in the future. And what do I mean? So my wife was diagnosed with stage 3A breast cancer that was ER positive, progesterone positive, and HER2 negative in 2011. She's Korean. How many New England Journal articles are there on 50-year-old Korean women with stage 3A breast cancer with those biomarkers? That would be 0. But Harvard has 17 hospitals. Now, they don't like each other very much, but they do share data with each other for this kind of thing. So I used an open source tool called I2B2. You can download it, .NET, Java version's available, to mine the data across 17 hospitals and say, for Asian women of this age with this cancer, what were their treatments and what were their outcomes? What we discovered is Taxol, good drug, but in Asian women, causes neuropathy, causes the hands and the feet to get numb. My wife's an artist. So saying you're cured but you can't work ever again wasn't a desirable outcome. So what do? A clinical trial of 1. We took her Taxol dose down 50%, treated her through the course of chemotherapy, radiation, and surgery, and today she's completely well and completely functional, and her hands and feet are just as they were before treatment. That's the kind of thing we need to do. Now, what about telemedicine and telecare? So Daniel may not know this, but I do 900 telemedicine consultations every year myself. I am, I think, the only person at Harvard who is not only credentialed for telemedicine and telecare, but malpractice insured for practice in all 50 states. And what do? I have the weirdest specialty ever. I am the nation's expert in poisonous mushrooms and plants. So if, let's imagine you had a 3-year-old who went out and munched a lawn mushroom, I get the photo, I have to do the diagnosis, and importantly, I keep that 3-year-old out of the emergency department. Because if you give activated charcoal to a 3-year-old, more ends up on the parents than in the 3-year-old. Or if the 16-year-old, not that anyone would have any memory of this, looks for the little green staining ones that grow in the cow patties, little psilocybin-containing mushrooms, I could say, don't worry, put them in a dark room, avoid gastric lavage, like imagine being on mushrooms and the big hose gets stubbed, not a good idea. So point being, here I am with my iPhone receiving images and cases from all over the world, and through just a virtual interaction, developing a care plan that keeps them healthy. It's low cost and it's efficient. And that's the kind of expertise we all need access to, whether we're urban or rural, whether you're in the US or elsewhere. One challenge, however, is policy. I'm licensed in California and Massachusetts. So what happens if a doctor in North Dakota consults me for a mushroom poisoning? Well, what I do is I say, my advice is, this mushroom is a Russula emetica. Emetica in Latin means makes you vomit. Don't worry, it'll all be okay, nothing you need to do. And the doctor in North Dakota, using the license from North Dakota, decides to believe me or not, and to offer treatment or not. And that way we get around some of the policy barriers we're seeing now. Well, and lastly, blockchain. So I said you have to be a little careful here. There are 3 probably good use cases. Believe it or not, sometimes Harvard doctors are sued for a malpractice. It does happen. And I'm asked, provide the medical record for the last 20 years to the plaintiff attorney. And I do. And they say, oh, but this has been changed. It's incomplete. You've deleted all the parts that implicated the badness. If you use a blockchain audit trail, when a note is signed, put a hash of that note into the blockchain, 20 years go by, you can validate the note has not been changed. Or use it to show patient consent. Or use it to incent patients to contribute their data, or incent them to comply with medications or treatment regimens with a micropayment. Those are sort of reasonable ideas. But if anyone comes to you and says, we're going to put your Fitbit data on the blockchain and it's going to be a great big data analytics something, probably not. Well, Daniel, I know we're running tight on time. Very last thing I'll say is the technologies I've shown you today are in production now. We're using machine learning to read all the faxes that come into Beth Israel Deaconess, apply metadata, and insert them into the medical record. We're using mobile and Internet of Things to keep congestive heart failure patients healthy in their homes. And we're pushing data across the community to track where you're receiving care to help coordinate the best care at the best cost at the right time. So I hope you have a great rest of your evening, and I think I will see you at our evening festivities. But hey, did you have 1 or 2 questions for me?
First of all, thank you, John. Amazing.
Certainly.
Thanks for all you've done to catalyze health innovation across the planet. One of the challenges that we often see is, whether it's policy or you're moving someone's cheese, is the misaligned incentives. What have you learned across your journeys that can align incentives, to use that connected blood pressure cuff to manage your hypertension, or allow the North Dakota doc to do what you do?
Sure. There are 3 ways to influence a clinician, and I am one, so I can probably say this. Pay them more, make their lives easier, or help them avoid public embarrassment. And what do I mean by that? So imagine that if Medicare and Medicaid wanted to, say, publish quality scores and name the clinicians. Well, if your quality scores looked bad, you'd be very embarrassed. So if you say, hey, but use this technology and your quality scores will look good. Oh, and you'll get home earlier. And you'll probably even get paid more. And what's this paid more stuff? Well, in a risk environment, and about $2.5 billion of our contracts right now at Beth Israel Deaconess are risk contracts, right? We look at total medical expense. So we had this one guy, COPD patient. Every August, hot and humid. He comes into the emergency department, gets a $20,000 hospitalization. You know, that's good care, but probably bad for him and bad for society. So what did we do? We went to Home Depot and bought him an air conditioner for $269. And you know, he hasn't been back to Beth Israel Deaconess. He's still alive. It's all good. But that's the alignment of incentives, because we're now paid for outcomes and total medical expense and not just heads in beds.
Perfect. And last question. There's a lot of available information from pharmacogenetics to your digital exhaust, but the EMRs today are still mostly billing engines. When are we going to see real sort of decision support to pick the right statin or blood pressure med for you integrated into the workflow of a clinician?
So this is a brilliant question. Do I believe that Epic, Cerner, Athena, and the like will be the next innovators? I mean, they're fine companies. The answer is no, right? It's you guys. And each one of those products has, in 2018 already, these early fire APIs. 2019, you'll see even more, so that innovators can create cloud-hosted decision support services and mobile apps that layer on top of the EHR. So watch for the innovation around the EHR, not in the EHR.
Perfect. Thank you, John Halamka. Catch him at dinner.
Thank you.